All right, so pain. What is pain?
Whatever the patient says.
Whatever that patient says it is, right? We've heard that. That's been beaten into you enough? Okay. Good. I'm glad. We've done a good job then. All right? It is complex. It is multidimensional. It is usually the number one reason people seek medical attention, right? This hurts, this hurts, this hurts. My stomach hurts, my leg hurts. People don't go to the hospital and say, I'm feeling great, I think I have a brain tumor. Can you check me out? They say something that's hurting, that's bothering them. It is subjective. It is whatever the patient says it is, and it exists whenever the patient says it does. If the patient is laughing and they tell you they have a pain at 10 out of 10, what's their pain? A 10 out of 10, okay? This is the more like medical definition. It is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. Very fancy. It's what the patient says it is. But we have to be careful because if it is what the patient says it is, there's a whole group of special patients, right? Special populations. Like who? What? Go ahead, say. What? Drug seekers? Who else? Huh? People in a coma, right? Can a person in a coma tell you that they're in pain? No. So coma, dementia. It makes it really hard with those people. Do they still have pain? Heck yeah, they have pain. So it's our job to look for signs and symptoms that our patient in a coma is in pain. What are signs and symptoms that they're in pain? Grimacing, what else? Blood pressure, vital signs might change. What else? Sweating.
Hold in the fetal position.
Yep, they're changing position, they're restless, they can't get comfortable. So we're looking for that. Somebody said, so look for nonverbal, and we want to treat them as though they're awake, right? So if we notice them grimacing, if we notice they're uncomfortable, we're going to go ahead and treat them. And then what do we do with a awake patient? If I say I have a headache, and you come and give me ibuprofen, what is your next step as the nurse? Reevaluate, right? Anything in nursing we are following up with. We don't just do things and say, it was great treating you, have a great day. We do something, and then we follow up with it, right? So we have to do the same thing with a nonverbal patient, whether they just have dementia or they're in a coma. We have to follow up. Did that work? Are they grimacing less? Are they seem more relaxed? And if not, what else can I do? And we always investigate possible causes, right? Whether they're awake or not awake, we want to know why they're in pain. And that's a little harder when they are not awake to tell us this is what hurts. Or I have lower back pain, so laying flat on my back hurts. I need to sit up a little bit. They can't tell us that. So we may have to investigate. End of life. This is another special population, right? Why? What are caregivers afraid of? The patient's in pain, they have like intractable pancreatic cancer, and they're...
You're going to dose them out and they'll stop breathing.
Yeah. So patients are afraid, don't give them too much because I don't want them to stop breathing, right? So you have to be careful. Sometimes if you give even a terminal patient too much, you may have to back off. You may have to give a little Narcan to make sure that they're breathing okay. But you can't be afraid to give it because of what it may do, okay? So if they're hurting, you give them the pain medicine. If their respiratory rate drops, we can give them a little Narcan to knock it out, right? But we still have to treat the pain. And a lot of times they're afraid it will hasten their death, it will hurry it up. And we have to educate them. And then someone already said this, drug seekers, right? We're afraid that, well, this person came in, they're an IV drug user, I'm going to go ahead and, if I give them morphine, I'm going to make them even more. Or someone who doesn't ever take drugs, like, someone who's totally opiate naive may say, I don't want morphine because then I'll become addicted to it. Well, that's where we come in, because we need to be educated about the terminology and what effects it has on the patient so that they get the right treatment. Why do we care? Obviously, we don't want anyone suffering. There's lots of physical and psychosocial dysfunction. Pain can cause immunosuppression. It can cause sleep disorders. It can have effects. This biosocial model of pain talks about the psychosocial, the physiological, the cognitive, the behavioral, the socio-culture aspects of someone who's in pain. Does anyone know someone in chronic pain or anyone that's had, like, been through a bad car accident or anything? Those, I mean, they can get withdrawn, they get angry, they get frustrated. So it not only affects their mind, but it does affect them physically too. If they can't sleep, are they going to heal as well? Are they going to function as well? If their leg is in pain, are they going to get up and walk as much? No, then that's going to put them at risk for pneumonia and those type of things. So we want to treat pain so that we prevent any other physical or psychological problems. So we classify pain by the pathology. So nociceptive versus neuropathic. And by the duration, whether it's acute or chronic. So this is nociceptive pain. And again, this gets a little confusing on your module. I think it still has, so module 2 is threats to pain, sleep, rest. So you've got the content outline and you've got this little chart thingamabobber, right? In there it's got, does it still have somatic and then neuropathic, nociceptive, and visceral, right? So you basically have nociceptive, which is somatic and visceral, okay? And then you have neuropathic. Does that make sense? All right. So when you're doing your box, you may want to change it up a little bit to reflect that, to make it less confusing. It's just somatic and visceral are where the pain is coming from. So there's damage to somatic or visceral tissue. Those are the two types. And we treat this with opiates and non-opiates. Somatic is localized. It can be superficial. So someone cuts my arm, that's where my pain is. It's a somatic pain. It's localized and it's superficial. It's sharp. So anyone who's ever cut their finger, remember that feeling? A sharp pain can burn a little bit. Versus deep, and that's from bone or muscle. So someone who breaks their bone. Anyone broken a bone before? It hurts, right? And you've got and it's a sharp, burning pain. It can also be deep, aching, or throbbing. So somatic is a localized pain. It's in one area. It's not my whole back and legs and everything hurt. It's specific. It's here it hurts. It's here it hurts. And it's either because I cut something on the outside or something inside, like I tore a muscle, I broke a bone. It's very specific spot. Visceral is some kind of tumor involvement or obstruction, and it arises from internal organs. So, or any lining of the body cavity. So it can be a little less localized because it's not going to be like a specific spot that got injured. So let's say, I'm trying to think of an example. Like let's say you had a bowel obstruction. Your entire stomach, that your back may hurt. And it's in a response to inflammation, stretching, ischemia. So let's say that you have a bowel obstruction, right? And you've been eating, so you have a bunch of stool in your bowel. So your bowel's going to stretch. It's going to be inflamed. You're going to have abdominal pain. You're going to have back pain, flank, side pain. And it's going to be this intense cramping. A lot of times, for kids, the number one reason that they come in for abdominal pain is because of constipation. So, and then they'll describe this intense cramping pain. So both somatic and visceral are nociceptive pain. Somatic is just super localized, and visceral basically comes from an organ. Neuropathic pain, on the other hand, is basically from your CNS, your nerves, your central nervous system. When you think of neuropathic, think CNS. People describe it as different types of ways: a numbing, a burning, a shooting pain, a stabbing pain. And it can be sudden, it can be lingering. Neuropathic pain is really hard to put your finger on. It's not very classic. If I break my arm hurts until I get it fixed, right? But with neuropathic pain, we don't always know the cause, and it doesn't always follow a consistent pattern, so it's harder to treat. We use opiates and adjunct therapy. So things like tricyclic, antidepressants, anti-seizure meds. Oh, I'm going back. And it can be centrally generated or peripherally generated. So central from the central CNS or peripheral. Neuropathic pain is when you think of like phantom leg syndrome, like someone who gets their leg amputated, but they still feel pain there. That's more peripheral. So we defined it by whether it's nociceptive or neuropathic, and then both of those can be defined as acute or chronic. So the difference are based on the cause, the course, the manifestation, treatment. Breakthrough pain doesn't really fit into acute or chronic. This is pain that, despite your pain being treated, you get a sudden onset of pain. So it doesn't really fit into either category. You're being treated for acute pain. You're being treated for chronic pain. And breakthrough is all of a sudden you hurt again despite the fact that you're on medications or on therapy. So acute pain, sudden onset. It usually lasts less than 3 months. And it diminishes with healing. So if I break my arm, it hurts really bad right then, right? Break my arm, it hurts. As my broken arm heals, my pain goes away. It could be mild to severe. So acute pain doesn't have to be, it can hurt really bad. It's just not going to last a long time. So don't think of acute and chronic as quality of pain. It's the quantity. Does that make sense? It's just a shorter amount of time. And normally you can find out why you're having the pain. I was running and I tore a muscle. I was skiing and I broke my leg. I was chopping vegetables and I cut my hand with a knife, you know. All those things happened to me. You get some clinical manifestations, right? Their heart rate's going to go up, their blood pressure's going to go up, respiratory rate's going to go up. But the big difference between acute and chronic pain, like I said, is that because with chronic we don't always know what causes it, and with acute we do, when you treat the cause of pain, normally the pain goes away, right? If we have a broken arm and we treat the broken arm, the pain is going to go away. Now, we may need to give some opiates or non-opiates. Like if my arm's broken, while they're fixing it, I may need some morphine to make it feel better at that time. So I may need some treatment with that, but I treat the cause and I use medicine to make it go away. If not treated correctly, it can lead to chronic pain, right? So that person who broke their arm but didn't get it set right, it can lead to chronic pain for that patient. So that's why we want to make sure that we treat the cause when we know it. Chronic pain is persistent. It's pain that doesn't go away. It can wax and wane. So in 1 minute, the patient can be in excruciating pain, and the next, they say the pain's a 1 out of 10. The pain is always typically there. It's just the severity of it varies. It can gradually get worse, or it can be a sudden onset. They could just be sitting there laughing and talking with you, and then all of a sudden start crying that they feel pain. We oftentimes, like I said, we don't know the cause. This is when we think about like fibromyalgia and other CNS disorders. It's hard for those, and it's hard for us to treat because we can't see why they're in pain, and it's hard for us to understand. Often the impact of the pain is way more than the objective findings. So that means that the patient is like, can't walk, but yet there's no reason she can't use her legs, or she or he. The patient is crying uncontrollably and depressed and won't go out during the day, but physically we can't find anything wrong with them. Their heart rate's good, their blood pressure's good. We do an exam on their body, there's nothing we can find. They typically don't move as much, although physical activity helps with chronic pain. They are tired all the time. They withdraw from others. They're anxious and depressed. So our treatment goals are different. So unlike with acute pain, our goal to treat is to treat whatever caused the pain and control the symptoms. This, we're just going to try to control the pain as much as possible. If we gave them as much pain medicine as they wanted, we would be putting them into a coma. So we're just controlling the pain as much as possible while trying to enhance their quality of life. Because right now, not moving around, sitting at home all day, that's a pretty crappy quality of life, wouldn't you agree? They're not enjoying life with their friends, their family, whoever. So we're just doing things to help increase their quality of life. I believe this is still table 9.5 in the old. Can I borrow? I don't want to be a liar. Yeah. So it's table 9.5 in the 9th edition. I'm sorry, I don't know the 10th edition yet. But it says core principles of pain assessment for those with the 10th edition. Page 120 for the 9th edition. We all know this, fifth vital sign. It's really important. If pain is whatever the patient says it is, then we need to understand what works and what doesn't work for them. Just because we know that morphine normally works for this type of pain, if the patient's gotten morphine before and it does nothing for them, then there's no point in giving it. We've got to know what works and what doesn't, what strategies they've used. And we base the treatment on the patient. What is their goals? What is their beliefs? Maybe they don't believe in opiates. Maybe they want to use adjunct therapy. What is their expectations? And not just the patient's expectations, but oftentimes what are the expectations for the family members involved, especially when we're talking about chronic pain or with children. Some people are okay with a certain amount of pain, right? Some people walk around in excruciating pain a lot, and their expectation is, if I can, get up and have my family come visit me, that's good enough for me. Well, other people, that wouldn't be good enough for them. They may have the expectation that I want almost all my pain gone because I want to go running with my daughter later this afternoon. So you have to work with the patient and their expectations. And you sometimes have to be like, are those expectations realistic? There are drug and non-drug therapies, a holistic approach. So there's lots of people involved, the nurse, the physician, the family. They might need physical therapy, occupational therapy. And we consider a lot of different things. Scheduling, titrating, around the clock versus as needed, side effects of the medications. Some people would rather live with the pain than live with the side effect of a medication. And as always, we want to see, are we doing a good job? Evaluate the effectiveness. This is all in that table. Is anyone going to freak if I go on? Okay. So there's 3 main categories of how we treat with drug therapy. Non-opiate, opiate, and adjunct. And we can treat with meds from one of these groups or from all of these groups. This is why pain control is such an issue for the medical field, because it requires a lot of fine-tuning. There is no one right answer to treat pain, because everybody, again, if it's what the patient says it is, how they perceive it, what their expectation is from pain control, then you're going to have to play around a lot to see what works for your patient. So non-opiates, they're typically good for mild to moderate pain. They have an analgesic ceiling. Does anyone know what that means?
They only work to a certain point.
Yeah, they only work to a certain point and then they're done. So, like non-opiate would be ibuprofen. I mean, you can typically, for an adult, 600, 800 milligrams is the max. If you give them 1,600 milligrams, it is not going to help any more than 600 milligrams, okay? So an analgesic ceiling means that there's a certain dose that that medicine will work at, and increasing it doesn't increase its pain effectiveness, pain control effectiveness. The nice thing, you don't have to worry. Patients don't get scared about non-opiates. They don't get scared because they're like, I'm not going to get addicted to ibuprofen. I'm not going to develop a tolerance because there's no ceiling effect. But because they're over the counter, they forget about things like, oh, if I take too much Tylenol, I'll go into liver failure. Or I'm taking my cold medicine that has Tylenol and my prescription medicine from my doc that has Tylenol, and I don't realize that I'm overdosing on too much. So you have to be really careful when patients tell you their medicines that they include anything over the counter. Non-opiates are great with opiates because they have what's called an opiate sparing effect. So they allow for better pain relief with opiates. So let's say you're giving morphine and you're giving 4 milligrams and then 5 milligrams and 6 milligrams. Well, now we can give morphine 4 milligrams or 3 milligrams with 400 of ibuprofen. And it helps so that you still get better pain control with lowering the opiate dose. So it's an opiate sparing effect. So you don't need as much opiate to get the same pain control when you use a non-opiate with it. It helps lower those pain scores. You hanging in there? So the 3 big ones are aspirin. Aspirin is used for mild pain, but you have to be really careful because of what? Ulcers and bleeding, right? Especially GI bleeding. Tylenol is great. It can be treated for pain or fever, but it doesn't have any antiplatelet or anti-inflammatory effects. So if this is an inflammation problem, if there's some inflammatory process happening, Tylenol is not your best choice. It's metabolized by the liver. Why is this important? Yeah, so if your patient with liver disease comes in and the physician, so again, could this be something you see? 100%. Your patient with liver disease or stage 2 liver cancer comes in, the doctor writes the following orders. Which order would you question? The one with Tylenol would be it, right? Or if they have a kidney problem, you're going to want to be careful. And again, this is that's something you're going to want to do as a nurse. In your care plans, that's what you're going to do. In your IPAs and your well elders, these are the type of things you're looking for. Again, it's often used with opiates to create that opiate-sparing effect to help lower pain scores. Has fewer side effects, though, so that's a nice thing. So it has no anti-inflammatory properties, so it doesn't really help if there's inflammation. But when you can use it, if you have a healthy patient, no liver disease, it's not an inflammatory process, Tylenol is a good choice because there's very few side effects with it. NSAIDs, so ibuprofen, they're like aspirin, but they work a little bit better. They have a lot more side effects though. GI, renal, hypertension. And you want to be careful because just like with, it doesn't have as much of a risk of bleeding as aspirin does, but if your patient does have any peptic ulcer disease, you do need to make sure you use some kind of PPIs, like proton pump inhibitors. You guys learned about that in 3 with adult nutrition. Opiates, you don't need to know this. They're categorized. So opiates, there's a big range of opiates, right? Unless you're going to become like a pain specialist or like a pain nurse or whatever, you can dive really deep into this. I want you to stay on the surface, okay? Stay with me in the shallow end. So they are categorized by their physiological action, like they're an antagonist or an agonist or antagonist, whether they work for or against, and what receptor they bind to. So there's mu receptors, kappa receptors, delta receptors. You don't need to, and your book I think goes into all of that. You don't need to dive into all of that, okay? They're basically used for constant pain or breakthrough and procedural pain. So they're really good. So let's say you have a patient that is in constant pain. So you put them on a long-acting opiate, and then they have a procedure done, and you may, and they get something done to them, a procedure that's painful, or they have breakthrough pain. Then you might use a short-acting opiate on top of that. Okay. That's different than the non-opiates, which is more that moderate pain. So usually there's no analgesic ceiling. You can just keep giving them higher and higher and higher doses to get the pain, the desired pain control that you need. We already said acute and chronic. It's more moderate to severe pain. There's lots of examples out there. Morphine, oxycodone, codeine, methadone, tramadol. The list goes on and on. But their side effects are important, and that's what you guys need to know, because you won't be ordering these pain medicines, right? The doc is going to order these. Your job is to evaluate the effectiveness of it, to see if your patient's getting any pain control with it, and to see if anything bad is happening to the patient. So constipation is the most common use, or most common side effect. So, yep.
Is that
It's what?
Is that green or black?
Green.
Green.
Yep. Yep. I don't know. It is. This screen doesn't show up as pretty as the other screen in 212. We were always in 212 last semester because we had like 400 of you, I felt like. So constipation's most common. So if we know that our patient is on morphine and they're getting it even around the clock, or they have it ordered as needed but they're getting it all the time, and I'm looking at the PRNs, what am I looking for to make sure my patient's on? Colace, right? Some kind of stool softener. Because if they're not, that's my job as the nurse, is to say, hey doc, I don't see any Colace, this patient's getting morphine, last bowel movement was 2 days ago, can we get some? They can get some nausea, vomiting. So we can give some antiemetics with it if we want, make sure it's taken on a full stomach if they can eat. Now, the most common fears is going to be sedation and respiratory depression, right? That's what people are afraid. That's why they're afraid to take opiates. That's why they're end of life. They're afraid to give them because they think it's going to hasten that death. sedation and respiratory depression are a little bit higher. The likelihood is a little bit higher in opiate naive people. So people who have never had opiates, the chance of having some respiratory depression and sedation is a little bit higher, but nothing that needs to be concerned and not enough reason that we shouldn't be treating, right? Because the nice thing about most opiates is that we have an antagonist against it, so we can give something like Narcan to act against it. They can get itching, pruritus. This is typically more with epidurals. Anyone's had a baby that had an epidural? They got so you want to make sure things like what? Your patient's nails are kept short, that you can give them something for the itching. You use other things. Yep, Benadryl. Adjunct therapy. It's used in conjunction with opiates and non-opiates. There's a whole list, okay? I'm just going to put it all up. I don't think you need to freak out about any of it. All right? So there's, like we talked about, antidepressants, anti-seizures, all these different things. You've heard of it that a lot of times they'll do like a tricyclic antidepressant with an opiate. And they're more often used when we're trying to treat chronic pain and we can't, maybe we've maxed out on morphine and we've added Tylenol and ibuprofen and we're still not getting a good effect. They'll try things like these tricyclic antidepressants to see if they have any effect for the patient. GABA receptor. Don't worry. There's non-drug. Non-drug is great because we can do it without a physician telling us to, right? Unlike the other treatments for pain, we need a physician's order. But if we walk into a room and we've given them their ibuprofen and they're having some breakthrough, we've given them their opiate and they're having breakthrough, there's things that we can do to help them, right? So, in addition, it helps decrease the dose of opiate or non-opiate that they may need. So if we can do some of these things, these are all examples. If we can give massage, if I have a headache because I have a tense neck, I could take a bunch of ibuprofen, or maybe a little bit of a massage will help release that tension, right? The guided imagery. I know it sounds silly, but for some patients to sit there and talk them through and say, okay, where's your favorite place to be? I imagine myself with my kids and it's the holidays and we're opening presents. That does something to the brain. There's tons of studies that show that guided imagery helps them because they turn their focus off the pain and they turn it onto something positive and happy. And it really helps them feel like they have a sense of control over their pain, especially those who have this chronic pain that are constantly feeling kind of crappy and they've tried everything else. When they do these things like exercise or does everyone know what the TENS thing is? It's like the little electrical shocky things. Acupuncture, they feel like they have control over that. They can do that themselves too. So why don't people get effective pain management? One, because of tolerance. So chronic exposure to a variety of drugs, and basically tolerance is the need to increase the dose of medication to get the same amount of pain control. So you were on morphine 2 milligrams and that worked, but now my pain is, and I was able to always keep my pain at a 2, but now my pain sits at a 4. And so I have to increase my morphine to 3 to get my pain back to 2. And now I have to increase my morphine to 4, so it's a tolerance. So if tolerance develops, which is normal, this is not, when people think that they're addicted to a drug, this is not an addiction. This is a tolerance. So we have to rotate drugs. So if we notice that we have to keep bumping up our same, medicine to get the same desired effect, then we may need to add a non-opiate. We may need to add an adjunct therapy to that. Or we may need to rotate from morphine to codeine or to whatever, Dilaudid. Physical dependence is, again, normal too. And it's a normal response to ongoing exposure to the drug. So basically, they get withdrawal symptoms if the drug stopped abruptly. The one that you probably all are familiar with is caffeine, right? So if you guys have had your caffeine every day, or your Monster, or your whatever, if you don't have that caffeine, what do you get? Headache, right? So this is normal. It's a physical dependence. So tolerance is normal. Physical dependence is normal. Those aren't bad things. We just need to know that they can happen, and we've got to treat them. So with tolerance, we rotate the drugs. With physical dependence, we have to taper the drug. So we just can't stop. You can't go from 3 Monsters a day to nothing. You may have to go to like 2, well, 1, if you're drinking 3 Monsters a day, you're going to have like cardiac arrest. But maybe, I don't know. But you're going to go to 2 Monsters and then 1. You just have to taper it off a little bit. Pseudo addiction, we're not going to talk about. You don't need to know. Bless you. An addiction. This is not normal. Okay? In fact, I just had to renew my nursing license, and this is now one of the CEUs that is required for every 2 years. Did you notice that? Have you had to renew yet? Oh. So it's brand new. You have to actually take a course in how to recognize addiction in your coworkers as part of your license renewal. So it's become a big thing. So addiction is not, yeah. I just renewed it over the weekend. Yeah. So basically, it is a drive to obtain and take substances for another reason other than their therapeutic value. So I take morphine because I hurt, normal. I take morphine because I really like that high, not great, right? If a patient has tolerance, if a patient has a physical dependence, that does not increase their likelihood to becoming addicted. And this is where you guys become important in educating patients. Because when a patient says, I'm scared to take morphine because I don't want to be addicted, you can educate them and say, you may develop a tolerance to it and you may develop a dependence to it, but that's not an addiction. And we have ways to fix tolerance. We have ways to fix a dependence. An addiction is something different. The hallmarks, they have compulsive habitual use, they have loss of control of the use, and they have continuous use despite harm. So they will steal from their family members. They will, despite the fact that they black out and had unprotected sex, they still want to get up the next day and use it. The fact that they're going to lose their job doesn't become important anymore. The fact that their kids might be taken away from them. They can't control it anymore. Despite the fact that all these negatives might happen, they just need to use it. Those at risk are young age. If there's any personal family history, especially like any mood disorders, mental disease, they're more at risk. So a nurse is caring for a post-op client. Which of the following assessment findings is most reliable that the client is experiencing pain? A, a blood pressure of 166/90. B, pain rating of 9/10. C, client grimaces. D, client refuses to eat breakfast. Who wants A? B? C? D? Good. It's whatever the patient says it is, right? So it's B. All those other things are indicators that the patient might be in pain, but the most important thing is what the patient says. A nurse is performing a pain assessment on a client. Which of the following subjective data describes the quality of the patient's pain? A, my pain is so bad that I cannot sleep. B, my pain feels like a tight feeling in my chest. C, my pain started last week after I went on a hike. D, my pain feels better if I rest in an upright position. A, B, C, D. It's B. And so this is a good way to look at it. What is the stem of the question asking you?
Subjective and objective. You can't measure A, C, or D.
All right. Yep. Subjective quality of the pain. All right. What does the quality, what does it feel like? Not what makes it feel better, D. Not when did it start, which is, all those are important. We want to know when does pain start, when does it stop. We want to know what makes it better. We want to know, all those things, but look at the stem of the question. What is the question asking you versus what distractors are we putting in the answers? Okay? All right. Anyone have any questions regarding pain?